Okay, so loading YouTube to make it live. Once it starts, I'll start recording screen as well here, and we'll be good morning from New York. Welcome to the second virtual forum of the World Network of Psychiatric Trainees. Sorry, I think it was an echo. Good morning from New York. Welcome everyone to the second virtual forum of the World Network of Psychiatric Trainees, WNPT. Thank you very much for dedicating a little bit of your time this Saturday. And we know colleagues are joining this forum today from more than 20 countries in all world regions and from almost all time zones in the world. So we deeply appreciate those who are joining from as far as Indonesia, or who will be joining from New Zealand, because it's late night there. And we will have people, at least registered people, from time zones ranging from Minnesota in the Midwest in the United States to Indonesia and New Zealand in the East. So I'm Victor. I'm a psychiatrist, originally from Spain, and now I'm completing a fellowship in child and adolescent psychiatry at New York University here in the United States. In 2018, with the collaboration of many colleagues, I founded the World Network of Psychiatric Trainees, which is now an online family with more than 230 members that are residents, fellows, and other official trainees in training programs in psychiatry from all over the world. WNPT offers a platform for collaboration, mutual knowledge, and collective efforts to improve psychiatric training and practice in all the countries in the world. And it's our struggle to make global mental health happen. And Dr. Jibril will explain a little bit more what is global mental health. And this network, WNPT, is open and free for current psychiatric trainees from any country. And if you are not a member yet, we'll share a link. And you can join us anytime using that link. Okay, now I was going to introduce the co-chair of this for this forum, Dolapo. Unfortunately, she had a family urgency, and we hope that she will be able to join us later if everything goes well with that urgency. But Dolapo is one of the young promises of Nigerian psychiatry. He's a 2020 awardee of the EFPT Mental Overseas Award of the European Federation of Psychiatric Trainees. She will be, well, if she's available, if not, myself and Aisha will be moderating the round for questions and answers after the featured talk by Dr. Jibril Handuleh. We encourage people to add their questions onto the Zoom or YouTube and to the chat anytime during the presentation or later, starting the question with an asterisk so that it's easier for us to distinguish questions from other comments. And we'll be trying to address all the questions. And after the end of the presentation as well, we will talk a screenshot with a grid view of the Zoom of the audience for our record and also for the social media. So those of you who want to be there, you can turn your cameras on. You can also have the cameras on all during the presentation. No problem. We'll just ask you to have the microphone muted unless otherwise instructed so that everyone can hear clearly the speaker. And we want to thank our social media manager, Aisio, if he wants to, he has the camera on, he wants to wave, but Aisio, Aisio is from Brazil, from the north of Brazil, and he's once again helping make this forum happen. And also many thanks to Baraka from South Africa, who will be joining as well us, and is the artist who designed this beautiful logo of WNPT, and also this poster and the poster for the previous virtual forum. And finally, thanks to, when they join, I'm not sure if they are already here, but thanks to Charlotte Michels and to George Sterku. Charlotte is from Belgium, and George is from Romania, and they are correspondingly the current and the past presidents of the European Federation of Psychiatric Trainees, and they have always support our network. And without more delay, it's my great pleasure to introduce the speaker of this forum. Is my colleague and friend Jibril. He's originally from Somalia and Djibouti, and he's now a junior resident of psychiatry at the St. Paul's Hospital, Millennium Medical College in Addis Ababa, Ethiopia. His personal experience and knowledge working, learning, and researching in global health in the region was prominent before he became a psychiatrist. Well, a resident psychiatrist. He's now a junior resident there. And he also had previously an experience in Europe, meeting other researchers and colleagues in Europe, and learning more about also the Western culture, and appreciating and enriching his cultural overview of the world. And truly, he's a champion of global mental health, and he had the honor to be recently designated by his colleagues at his hospital as the resident of the year. They had a ceremony a month ago, and he joined WNPT in July, so he's one of the most recent members, and he's eager to contribute to the network in East Africa. Jibril, today you teach us. Thank you. Jibril, when you want, you can start. Okay, well, we're having some technical difficulties.
Can you hear me now?
Yes, we can.
Yeah, I'm just back. I got lost in the middle. Should I start now?
Sure, you can share your screen.
Yeah, I shared my screen already. Yeah. Hello, everybody, and thank you very much for giving me the opportunity to talk to you today on global mental health and the effect of public mental health in low and middle-income countries. And I will first introduce the topic of global mental health, and then my experience working in the Horn of Africa.
Sorry, Jibril, we lost your screen, so I think you need to share it again.
Yeah, can you see me? Can you see it now? Let us see.
No, not yet.
No.
We cannot.
Is it here?
We can hear, but we don't see your camera, and we don't see your screen yet.
Let me share the screen. Sorry for the inconvenience.
No problem. If there's any problem, I have your presentation as well, so we can share my screen as well.
Now you should see my screen.
Now we see your face, your screen not yet, but
screen should be 1 minute.
Yes, no problem.
Is the screen there?
Not yet, but will be.
Will be. Good boss. Let me get myself in.
Don't worry, they're always, this is live. We don't see the screen yet.
It's coming, it's 1 minute,
Okay. Okay.
1 minute.
Okay, yeah, it's coming,
It should be there.
Okay.
No.
Now we see it.
Can you see it now?
Yes, now we can.
And you see, yeah,
Yes, now we see
yeah.
your screen.
Thank you very much, and sorry for the little inconvenience we had with the screen sharing. Today I will be talking about global psychiatry or global public health in low and middle income countries, and I will be sharing the story from the Horn of Africa. Before I do that, I will be sharing what global health is and why it's important for us as residents, fellows, and illegally psychiatrists have to understand. I'm Dr. Jibril. I'm a psychiatry resident. I'm from St. Paul's Hospital in Addis Ababa, Ethiopia. Thank you, Victor, today for chairing the session and also ACO for putting all this together. The objectives of the presentation will be to describe the historical background of global mental health and describing the global mental health from a health system perspective, just putting the things together. And I will define the role of global burden of disease in global mental health, and then I will go to discuss um, the Horn of Africa psychiatry, and I will define what that is. And the outline would be introducing global mental health, health systems, and public mental health, and global burden of disease study. This one I skipped, and then I will go straight to the mental health in the Horn of Africa. Then I will concentrate on my work. What's global mental health or public mental health is an area of psychiatry, which is now a science itself or art, and the process of creating a mental healthy society. This studies, researches, and looks into the practice of improving mental health for everybody. And it has a global outlook. When it comes into the consideration of disparities in mental health in treatment and the care people get across countries, within regions, and around the world. For global mental health, it addresses the physical, social, and economic burden of mental illness. As you know, people who practice mental health are only 1% of the global healthcare force. And 45% of people with mental illness, they live in a country like ours, where there is one psychiatrist per 100,000 people. In terms of global mental health education and training has been increasing among psychiatrists and among trainees like us, whether we are residents, fellows, and also illegally psychiatrists. The core issues we address in this lecture will be addressing the global situation of mental health in general and address mental health in areas of low resource and both conflict and both disaster settings, which is typically the story of the countries I will present. And there is that the issues of poor legislation and human rights protection of people with mental health is also very lacking. People with mental health disorders, they experience stigma and discrimination globally. And what are the social determinants of mental health, which are for everybody? This includes education, housing, employment, and other benefits of being a citizen of a country. Things like protection of your rights, your citizenship rights, your ability to marry, to have family, to have job, all that sort of things. And before I go to East Africa, I want to address this WHO poster, where it shows that people with mental illness in many countries have no access to mental health, particularly in low and middle income countries. That's where I come from. 85% of the people, like where I work, don't get mental health services at all. But in developed countries, maybe it's up to 50%. You are much better in the global north. Why we want to use health systems in the understanding of global mental health, because health systems is a system that helps us to understand the organization of resources, institutions, and people for the sole sake of delivering healthcare services. And the purpose is to meet the health needs of the target population, like the people with mental illness. And for global mental health, we address issues like health services, health workforce, which are us, the healthcare workers, information and data, medical products, financing, who will pay mental health issues, and mental health services and leadership governance, usually at high level of governance, ministries and people like that. And all this one combined, the whole aim is to deliver improved health and improve responsiveness of a mental health services, for example, and the protection protection of people who use the services from poverty and financial problems and social problems. And lastly, but not least, improve efficiency of services. And that's where we should aim. And that should be the outcome of any mental health service. As you know, there is only 1% of people who are working in mental health in general who are healthcare workers. That means 99% of global healthcare workforce work elsewhere. And among that percent, we psychiatrists, we constitute something like 8%, psychologists 8%, 7% I mean, and 43% of them are nurses. And when you see the whole world, 45% of the global population, they live in a country, like in our setting, where you only have one psychiatrist per 100,000 people. In terms of financing of healthcare services, in the whole world, there is little amount of financial and funding for mental health. For example, in low and middle countries, only 2%, $2, $2 are meant for mental health per person. That means every person can get like 2%. In many countries, it's even less than 2%. And in high income countries, per person is $50. And when you see where this funding goes for mental health, you can see that important areas of mental health, including suicide, and for example, maternal and child health are getting small amounts of funding, for example. In many countries, there's no suicide prevention strategy in every country. But in um, high income countries, we have 33% of them having national suicide prevention. For example, the amount of strategy that's given. When you see at the psychiatric beds, in low and middle countries, we have the least number of beds. Like we have 5 beds per 100,000 people. But in developed countries, we have 50 beds per 100,000 people. That's what you see in our practice in East Africa, for example. We don't admit patients because we don't simply have beds. Although this has been increasing 60% in the last decade, but that also corresponds with global population and increase, still the number of beds is very low. And this is very marked in low and middle income countries like our setting. For outpatient services, 90% of total service contact by people with mental disorders is through outpatient services because we don't have inpatient services. Policies and laws, two-thirds of the WHO member states, 193, have standalone policy or plan for mental health. That means so many countries simply don't have mental health policy that will protect the population with mental illness issue. When you see by the year 2000 the number of psychiatrists, most of us in low and middle income countries live in a country where we have only one or nothing per 100,000 population in terms of psychiatrists. And most of the psychiatrists are concentrated in high income countries. By the year 2011, the picture did not change so much. It is still the same. The number of psychiatric nurses, you can see, even low and middle countries, again, they have the least number of psychiatric nurses. For example, in high income countries, we have more than 50 psychiatric nurses per 100,000 people. And in low middle countries, we just forget that. They're very limited. Let's come to the Horn of Africa. Horn of Africa is a part of the world located between 3 continents. It is geographically located in Africa, but it's very close to Asia, Africa, and Australia. And it connects 80% of the world trade and the oil routes in the world. That means the region is so prone to conflicts and climate change issues, and our region is exposed towards internally displaced people and refugees, which affect the health, particularly the mental health of people. And mental health is the most neglected public health issue in our region. Then I will be introducing the mental health services of 4 countries, and I will be talking about Ethiopia, Eritrea, Djibouti, and Somalia. And lastly, I will talk about my own story of what I have been doing in the region. The region has 2 separate mental health system mechanisms and approach of expressing mental health. You have 4 countries that are neighbors, but the presentation and the context of mental health are different. 2 countries like Somalia and Djibouti are Muslim countries, and the presentation is very close to what you see, for example, in Iran or Egypt or Saudi Arabia or Lebanon or so things like that, or Morocco or Tunisia. And you have Eritrea and Ethiopia, which has the same clinical presentations of populations like in South Africa or Tanzania, Kenya, Nigeria, and so on and so forth. And they are in different WHO regions, Eastern Mediterranean region and the Africa region. This is where people go when they have mental health services. This is a study from Ethiopia. For example, 71.4% go to religious healer for the first time when they have mental illness. They never visit psychiatrist in their visit. 3.5% will go to GB, traditional healer 2.4%, psychiatric nurses 22.5%. Then where do you see the psychiatrist? Psychiatric care is so limited. And then when they are into the psychiatric services, um, most of them will again switch back to religious healer or traditional healer. Let me start with the first country, which is Ethiopia. I'm based and doing my residency in a beautiful city named Addis Ababa in the middle, with this blue marking with the white star. This guy is the head of the World Health Organization. He is our former foreign minister and the former minister of health of Ethiopia, who is a global champion for mental health. And now he's the head of the WHO. I am pleased to be in Addis Ababa and doing my residency. And this is the national health policy, the mental health strategy that this minister has developed, now the director of the WHO. And this is the hospital I do my psychiatry. This is the largest psychiatric hospital in Ethiopia with 300 beds. And now it looks like a small prison, maybe to you. That's the reality. And Ethiopia health profile, this is what the country looks like. By 2016, the population was 102 million people. This is the second most populous country in Africa after Nigeria. Gross national income per capita was 1,350 USD. Still, you can see it's a relatively poor country. Life expectancy at birth is 64 for men, 67 for female. Still, life expectancy is very small. What will be shocking you is the probability of dying under 5 is 55% of this country. Of the youth just die before they go to age 5. It's very shocking. Probability of dying between 15 and 60 is for men 246, for female 194. The expenditure, you see the total expenditure of health is only 4.9%. And imagine psychiatry is like 0.02%. Nothing for psychiatry. In Ethiopia, it is estimated that 15% of people are affected by a major mental health disorder or neurological disorder or substance, which is the same as other parts of the world. It is the leading non-communicable disease in Ethiopia. Depression and schizophrenia are the most common. Depression being the first, schizophrenia being the second. They outnumber, for example, other chronic diseases like an infectious disease like HIV and other communicable diseases. But the leadership is now interested in prioritizing mental health as an area of health. This is the 2010 data from the Federal Ministry of Health. It's outdated, but it's the current data we have. And you see the prevalence is at the same as other parts of the world. The human resources for a country of 102 to 110 million people, we have only 85 psychiatrists. This is an updated version that I updated from expert personal communication. At the time of the publication of the national strategy, it was only 27, but they have produced something like 85 psychiatrists. And 80% of these 85 psychiatrists are located in the capital. If you live in a town or in a village, you don't expect to see a psychiatrist at all. Neurologists is 45 for 110 million people. Nurses, psychiatric nurses 500. Psychologists only 14. We don't have occupational therapy, sadly. Like disorders like schizophrenia, there's no services for rehabilitation, occupational support, and that sort of things. Social work, they are only limited to 3 social workers. The number of psychiatrists per 100,000, 0.04. In a town like here, we have 8 million people, and we have something like 70 psychiatrists. Everybody is here. And Other towns, you don't expect anything. And here, the bulk of the work is done by psychiatric nurses, which are 0.59 per 100,000. For the governance, I'm using the WHO and building blocks. The country has no mental health policy. It doesn't exist. And there's no mental health law by that. And there's no mental health plan. That means people with mental health disorder are not protected legally. Or there's no national mechanism to help people with mental health disorder. Dedicated mental health legislation does not exist. That means there's no laws that will protect people with mental health disorder, like welfare, disability, general health regulation. Um, this is what we mean mental health policy. It is the statement done by a government, wherever it is, conveying an organized set of values, principles, objectives, and areas for action to improve mental health of a population. And in a country like Ethiopia and the four countries I will present, none exists. Financing. Mental health expenditure by the government is not available, but there are estimates. And 85% of whatever that is funded for mental health goes to mental health hospital, like the one I do in my residency that I showed in the first slide of Ethiopian mental health situation. That means mental health services in general hospitals, in primary care, they are not funded at all. And that means simply they don't exist. And if they exist, they are like the residents go and support patients in rotations and so on and so forth. The budget is apparently unsatisfactory in meeting the mental health resource and the needs Ethiopia has for this. And coming to mental health services and delivery, we only have one specialized mental hospital. That's what I do in my residency. The place that look it old and rough, which was a former Italian prison built 80 to 90 years ago. That's where we do our residency. General hospitals, like in my residency, is located in a general hospital. We only have outpatients, and then we only get outpatients in that place. Primary care, it is limited or non-existent. Psychiatry nurse services, they give the mental health services in rural areas. Other pathways of care, these are the two important things in Ethiopia. You have holy water centers for our Christian patients, where they go to a monk in a monastery or in a church, and then they get holy water treatment. And this is one of the earliest pathway of a patient with mental health disorder in Ethiopia. Like it's not like in many countries that's where you come from, where someone if they have mental illness like depression, schizophrenia, bipolar, or substance use, they try to see a healthcare professional. Here, they see their monk or their sheikh for treatment. Here is the shocking part of the health services delivery. Mental health outpatient facilities in the whole country. The total number of facilities and beds we have is only 57 for 110 million people. Daytime facilities are only three. Psychiatric beds in China Hospital are only 32 beds. And community residential facilities only one. This is 2011, no, and the things were not updated at all. And mental health hospital is one. That's where I do my residency, my clinical attachment. And beds in the mental hospital that I go, it's called a manual hospital, is 300 beds. When you see the number of beds and facilities for children and adolescents, it's simply non-existent. And then child and adolescent psychiatric services, we have small outpatient clinic that daytime facilities, which are three. One of them is a child adolescent clinic, and where we see patients. And residents, we go there in year three, the last year, because our residency program is only 3 years. Informal human resources, we don't have informal delivery of mental health services. Things like user or family support groups, they don't exist here. There are some artists like this, and singers and others who advocate for mental health, and they are very new, like songs, art, and things like that. And in mental health decision making, people with mental health experiences are not part of the decision making process. In mental health policies and mental health advocacy, although there is a good friend of mine I know who's part of the global mental health peer network, which connects people who have lived experiences of having mental health disorders. Community mental health, simply non-existent. But this country has one sentinel community mental health research area, and it's called Butachira. It's in the south of the country. And what they mainly do is the collection of epidemiological research in the epidemiology of common mental health disorders and primary healthcare research. But in terms of services to community, that does not exist, whether it's primary care or community outreach programs. Ethiopia is home to several UK aid and Canada Challenge grants in global mental health, and they work in the area of global and community psychiatry and primary care psychiatry. And it's only research based. It's not translated into services yet. Um, International collaborations that you will see here in this country include University of Toronto that gives Ethiopian residents their subspecialty training in psychiatry, like child and adolescent, forensic psychiatry, women's mental health, um, adult psychiatry, forensic, substance addiction psychiatry, so on and so forth. King's College London, University is here, Harvard's here, and then we see them. They teach the residents from time to time, and there are some of German universities too. And some of the grants that work on the primary psychiatry research and in community psychiatry grants include Prima and Emerald, and then you can read what they have been doing over the course of years. This is where the people go if they have mental illness for the first time. Either they go to their Orthodox Christian monk, it's here that we call that holy water treatment, or they go to their sheikh. And these are where people go. For example, here in Addis Ababa, we have a monastery which is very famous for people with mental disorder. And they have a lot of patients, even more than our inpatient units. And this is called Mount Ancestor St. Mary Church. This church has a lot of patients where patients come for holy water treatment instead of mental health services treatment. They get water and then they get the holy water because people here have religious or cultural connotation to mental health. This is a study done in Ethiopia. They ask it for your early time that you wanted to seek mental health disorder for treatment. Where did you go? The majority went to religious or traditional healer or a general practitioner. Then you see, even if they are in early or delayed. Here, what we have is that many patients will be seen so late. For example, last week I saw a patient who had schizophrenia, who had 17 years history of sinus acceptance persistent with schizophrenia. He presented just 1 week ago, and this is a delayed presentation. You don't see this in many parts of the world, but here it's very common. You see some people, some folks who had mental illness for 15 years, 10 years, 7 years, 25 years, even up to 32 years, who might be presented for the first time to us in psychiatry service. They go to religious healer or traditional healer. Like the patient that I met who had mental illness for 17 years, he said that he came just to know he had mental disorder just a week ago. The family said they only came to know this just a week ago. Let's go to the second country, Eritrea. This is a country in the east of Africa, bordering Ethiopia to the south, North Sudan, East Red Sea, and to south to Djibouti. This, I don't know if you have ever heard, this is a Italian-speaking country, an English-speaking country. It's the size of U.S. state of Pennsylvania. The population is just 6 million by the year 2020. This country, when you look at the mental health services, there is no mental health services, there's no mental health policy, there's no mental health plan. And the expenditure for whole health is only 1.9 to 1% of the total health budget. For psychiatry, they give that 1.9, or almost 2% of the total health expenditure goes to psychiatry. And they have only one mental health hospital, and that gets 74% of the total mental health budget. That means if you have mental illness, it's very difficult to be treated in Eritrea. You don't have mental health training for physicians and nurses. There's no residency, no psychiatrists. And GPs and nurses are the only source we have for any psychiatry service. And this is one hospital, only 13 beds in the capital. That's what you have. The availability of seats and beds for an outpatient facility is only 3%. And psychiatric beds, there's no psychiatric beds. In a general hospital, having mental health hospital is only one. You have only one hospital. and the beds are so limited. You don't expect anything for child and adolescent psychiatry at all. Patients treated per 100,000 is only 135 patients. That means around more than 800 patients will not get mental health services. And this according to the WHO data for the country, because WHO collects national mental health services data in the World Atlas report collected by WHO 6 regions. Patients treated in mental health day facilities is not available. Admissions to psychiatric beds in China hospital is 11 per 100,000 people. That means if you have mental illness in Eritrea, you just don't have services at all. There's no psychiatrist and there's no psychiatry residents in Eritrea. And there's no people who are training in psychiatry from that country, which is the reality. Nurses are the only people and the GPs who my people go to get mental health services. For 100,000 people, you have only 0.2 per 100,000 people for physicians, GPs, and nurses only 1%, one per 100,000. That means you don't even have people, human resources to treat mental health disorders. And in terms of medications spent for mental health and behavioral disorders, it's mostly negligible. It's nothing. For psychotropic medications in the whole country, you have something like for 100,000 people, only 1,712 USD, which means nothing. In a country like the US, it's like 1 week or 2 weeks refill for your medication, basically. That's what the whole people may have. That means medications are simply limited. And if you have mental illness in Eritrea, there's no even simple medication. This is for 100,000 people. This is another country, Djibouti. I am guessing or betting that no one of you have ever heard of it. It's like the smallest country in Africa. It has the size of New Jersey. It's one of the smallest, second or the first. Here, the picture is the same as Eritrea. There is no mental health services at all. You have 10 beds in a general hospital built by the French. It was like 90 years ago. When you look, because this country is an Arab-speaking country, when you look the mental health policy, substance abuse policy, national mental health programs, or mental health legislation, they don't simply exist. That means this is one of the countries in the region that has the least mental health services in the Arab world. When you see the number of psychiatric beds or psychiatrists or psychiatric nurses or psychologists or even social workers, you just go to Djibouti, you see nothing. There are only 7 beds in the whole country for 1 million people. For this is to show you that in many countries, we don't have no services for mental health. This is where I have been working previously, and that's where I will concentrate on my lecture. The last country in the region is Somalia, located in the eastern part of Africa, and it is the most eastern part of the continent, as you see. At the top is Asia already, and then this Indian Ocean all the way to Australia and India. This country has been going through 30 years history of war, and the place I was working was named Somaliland. You will learn about it, and the rest of the country is simply called Somalia. And it's an East African country. This country became an independent in 1960, but it was 2 regions that tried to unite. This part, which is in the gray, and the part in the light brown. And this country went into chaos in 1991, and there was no government. And the place I will present, namely Somaliland in the north, is an de facto state, and then they are independent. They're like Hong Kong, like Taiwan in Asia. They are not controlled by any country. They are just independent. Governance, policy, and planning are in place in this country. Currently, they are reviewing mental health legislation. And as you may not know, there's no psychiatry residency here. And everyone else training, people like me and others, have been training in residency programs in Egypt, in Kenya, in Ethiopia, in India. When people are coming, and we are trying to set up our psychiatry residence very soon when I graduate from here. Financing in general mental health services, financing is less than 0.01 of the health budget. This is something that we are fighting in the health policy setting, and then we are promising that this will go up to 10% of the health budget by the year 2022. Then we see if the politicians agree with us. Availability of mental health facilities, you have 13 beds for mental health services down there for an outpatient facility. People treated in mental health daytime centers were unavailable 10 years ago, but now they're available. Admissions to psychiatric beds in general hospitals. I will talk about this. They were not available 10 years ago, but we have some in the years to come. Persons staying in the community residential facilities were not available 10 years ago, but this time I will share what we have been doing down there. Admissions to mental hospital was only 10%, 10 per 100,000 population by the year 2011. This is the WHO Atlas data. Um, Psychiatrists by that time, the number of psychiatrists per 100,000 was 0.04, which is close to Ethiopia data. Medical doctors not specializing in psychiatry was 0.02 per 100,000. This picture is very close to Ethiopian data. Nurses is 0.45. Social workers, psychologists, occupational therapists are, as we speak today, not available. I only know one psychologist who just graduated a year ago. Then that will be only one per the whole country. This is my contribution to mental health systems in Somaliland. This is where I want to concentrate my. When I graduated as a medical doctor in Somaliland, what I did was that I had to help to contribute to the mental health services down there, where there were no psychiatrists, psychologists, occupational therapists, nurses, and social workers, and so on and so forth. For this, to set up psychiatry training, we first tried to integrate psychiatry in our undergraduate medical program. Then we had two medical schools. And then to do this, we have to set up a global health partnership with King's College London and the Institute of Psychiatry, Neurology, and Psychology down there, and the Maudsley Hospital, who were coming there and they were teaching students like me in the medical school and in the internship. And then what we did was that we had to apply grants together and set up mental health services, for example, for Somaliland. After my internship, and when I was licensed as a general practitioner some 9 years ago, I started to work on mental health services advocacy in Somaliland. This is what I did. Because that time there were nothing. There were no psychiatrists, psychiatric nurses, psychologists, and social workers or occupational therapists. We had to advocate that mental health is a medical condition. This is like starting mental health services from scratch. There were nothing. And then what I did to have my work done, I had to get funding. And then I got a generous funding from the UK Foreign Office, and this is called the UK Aid. And this went through a UK Global Health NGO, Navy Tropical Health Education Trust, based in London, to set up the mental health services. And then the grant was very generous. As a GB, I applied the grant with UK psychiatrists, mainly from the Institute of Psychology, Psychiatry, and Neurology of the King's College London. And then we had to set up mental health services from scratch from Somaliland. Later on, we had these partners from Karolinska Institute, the UK Aid, CEDA, and US Aid, who just came in later. And this is my concept paper first in 2012 when I was trying to establish mental health services as just a junior doctor. I was not a specialist. What I did was that I had to recruit resources for setting up mental health services for my people. And this is how it happened. When I got the grant application for 2 years, we had to set up an outpatient services and inpatient services and community outreach. Because there were no healthcare workers, we had to recruit core psychiatry trainees from the Institute of Psychiatry in London and their faculty to come here to our country and help us set up the mental health services together, where we had to have some year 3 core training or specialist registrars like general adult psychiatry, forensic psychiatry, people like that, addiction psychiatry trainees, then we could work together and treat patients and do the outpatient in 2011, like 3 days a week, and to 2012, 7 days a week. And then by 2012, late 2012, we have set up a 26 inpatient unit. And this helped me to choose psychiatry as a profession. That's why I'm now a junior psychiatry resident. And what we did was to make sure that a public hospital, like a general hospital, gets an outpatient and inpatient service. We decided to put mental health services in the existing healthcare system. In this time, we used the WHO evidence that the mental health hospitals were not good for people with mental health disorders. And then we put mental health services into general hospital and inpatient services. And then we had to work with private practice, make sure that we offer consultation like Alice and psychiatry. As you see in the Ethiopian pathway, we had a lot of religious and spiritual healers who were treating mental disorder. And we had to do is that we had to partner with them because they were the source of patients and traditional healers. And then we had to train primary care physicians and nurses on mental health and set up community mental health services. That's the first part of the grant. And then we had to establish consultation liaison services within the hospital. We started with nothing, and in the first year, we were seeing something like 500 inpatient, outpatients, and then we had to increase like 1,000, 2,000, up to 3,000 per year. This came through advocacy, working with government officials, with women associations, with the leaders, like the traditional leaders, the sheikhs, and the elders. And everyone was put on track. And for the mental health service profession in Somaliland, this is like a comment from the first maiden issue of the Lancet Psychiatry. They invited us to present our work as a comment in 2014. That's when the Lancet Psychiatry started. And then I was honored to deliver a paper on that. Areas this first grant also tried to reach out included areas of women's mental health, where we worked with both antenatal care for pregnant women and women who want to get pregnant in postpartum settings, and also with obstetric wards. We work with schools and we introduce school mental health services with a child and adolescent psychiatrist of mine who works at King's College London. We had to set up the first forensic mental health service in a prison for Somaliland. And we had to set up community engagement. This is the hospital that we had to set up in a teaching hospital, and this place was the dumping site of a hospital. And then we had to transform a dumping site in the psychiatric inpatient unit. And this was a paper for the American Journal of Psychiatry, the image section in 2018. And that's me and my colleagues discussing cases in 2018 when we set up the inpatient services. And this has been taken by a British friend of mine who is now a general adult psychiatrist in London. She just took the picture. This is what we did for the prison. What we had to do is that to reach out to prisons, because when there were no mental health services, people with acute psychosis or manic episodes or patients with violence or aggression would simply go to prison because there were no psychiatric beds, there were no psychiatrists, there were no physicians treating. And then the only solution was to put them in the prison. And then in the first phase, we had to train the psychiatric nurse, the general nurse in the prison to be able to treat and triage patients with mental health disorders. And then what we did, we set up this triage system where they can get the patients to us if they're sick. There's a story that I would like to share when we were setting up the services. The prison head, the military guy, and I had a discussion. The idea just came from talking to him in person in a hotel, like we have having a cup of tea or something like that sort of thing. He said, the only way we get patients with mental health disorders is that we are the psychiatrists in the country because there's no psychiatrists. We just admit everybody. Families will bring their sick person, and then we chain them for them because I'm not a physician, he said. I don't know what to do with mentally sick people. And he said, can you please do something for the prison? And can we work together to set up a mental health service? Then I got a senior mentor of mine who is a consultant forensic psychiatrist at Maudsley Hospital in London, my special friend, Ronan McLaughlin. Then me and Ronan had to visit the prison and we had to set up the mental health service and train the nurse in the prison for a whole year of 1 year. And he had to support me by distance and visiting me 3 to 4 times a year from London. And then what we set up was that when we trained the nurse, he was able to triage and know the signs and symptoms and try to treat them. And me and a nurse used to visit the prison like twice a week and offer forensic services. And we had to work with the prison and we had to work with the lawyers in the court system and train the police in the law enforcement agency. I would like to share the story of a 40 years old guy who had been imprisoned in Somaliland for 14 years for having hearing voices and having the delusion that people were controlling his mind and the telecommunication company of the Somaliland network were talking through his head. And by that, he got angry and then he attacked the telecommunication company. And what they gave him was 40 years prison term of just attacking an office. And it took me like 1 year to make sure that he gets only 30 years of his 40 years. I could not go beyond that, and they totally refused. It's an example of so many cases that we had to refer. And then we had this woman who had delusion of jealousy who killed her husband with a stone on the head. And then his head had to go into pieces. And then they gave her a life prison sentence. And that lady, because she was completely schizophrenic and she was a patient, we had to write a case and defend her with a lawyer. And then we had to release her. And then, as far as I knew, we were keeping in our ward for 2 years for her to escape from harsh prison services and 10. These are like few examples. I can give like hundreds of examples of people who have been simply arrested because they have mental health issues. And then we have to intervene in that. This is what we did in the schools. We had to train the teachers and other people who work in education on identifying, knowing, triaging, and referring children and adolescents with mental health disorder to our outpatients. And then we have to visit them once a week for up to 1 year. And for 1 year only, we had 300 individuals who required referral for either treatment or psychotherapy or follow-up. And after this pilot project, what we did was that we had to integrate child and adolescent mental health services into our own mental health services, where we have to train a nurse, and then this nurse has to support and triage and refer patients. And in our country, what we have, the main diagnosis for children and adolescents are ADHD, conduct disorders, depression, anxiety disorders, and autism, a lot of autism. And this is where we had to set up. And the people you see in the authorship are senior people at the Institute of Psychiatry at King's College London who were supporting me. For many places, because I was working in a small part of Somaliland, if you have mental health disorders, this is your way of getting treatment. This is very painful. Someone who has depression is supposed to face a hyena to treat their depression. What happens is that because there's no mental health services, they believe that, for example, if you expose somebody with something that's horrific, this may help them. And this is an article written by the Reuters in February 2020. And every one of you can go to the link and just see. Somalis tend to hyena to fight depression and mental illness. That is caused by lack of services. In the place that I used to work, this was not happening. But that's a small part of the whole country. In that part, we had partnership, we were putting things. So many of patients are here. What they get, their mode of treatment is only this chain, if you can see this chain. Because there's no medication for them, there's no psychiatrist, nurse, or chibi, or whoever who has ability to treat them. And this is a picture from a report that has been done by Human Rights Watch, and it has been written at Guardian in 2016. This is a 4 years old report by a good friend of mine who works at Human Rights Watch in London. And I had to work with her so closely when she was writing the report. And people with mental health disorders in a country like Somalia or Ethiopia or Kenya or wherever, the issues we have is the human rights abuses subjected to patients with mental health disorders due to lack of services, lack of human resources, and lack of policy that protect this vulnerable population in the community. That's why I was prioritizing like governance, human rights in the start of the lecture. This is another mode of treatment. Sheikhs and the religious people using mental health treatment. This is a guy, if you see on the right side at the top, he's using water cannon to treat things like depression and anxiety disorder. And they believe that water cannon chases away the chin or FL spread. And that means some people get suffocated, get head injuries, get trauma from this pumping with a huge amount of water. It's like a waterboarding, basically. And this guy is giving something that looks like a psychotherapy on the television, talking to patients, because there's limited number of psychologists who could give psychotherapy. And this is a sheikh who's advertising his religious treatment. This is what you see on the left side at the upper picture is what we call cupping. Cupping is like they use a cup, they would something hot like a burnt paper, and they just stack it to your back, and then gives you bruises. And they believe that these bruises will take your psychosis or your mood disturbances or stuff like that. Global mental health and our region, the Horn of Africa. The region has one of the most difficult case scenarios in the world when it comes to delivery and setup of mental health services, and at the same time, one of the most promising interventions in global health, because this offers a scenario where everybody can collaborate in setting up mental health services. Like now we have the King's College London, the Karolinska Institute in Sweden, and everybody can come in and work. This is a huge opportunity for institutions, illegally psychiatrists, or people who run grants like the Wellcome Trust, who showed interest in our country and that we all want to set up something that would look like a proper psychiatric services. Because we are starting everything from scratch. Mental health in its early stages of development in our region, we have specific issues that affect our region so badly, and this includes climate change, wars. We have a strategic location which brings a lot of international conflicts and interests, diverse ethnicities and religions. There's a lot of human rights abuses related to mental health issues and weak healthcare systems. How to address this may include the following. There are so many, but health policy will be number one for us. Make sure that policies are set in place that protects people with mental health disorder, advocates for resources, financing, and things like that. Health regulation, because you see these actors using hyenas or waterboarding or stuff like that. And this definitely needs regulation. And training of specialists. This region needs training specialists. I am based in Ethiopia. Ethiopia has only residents in this country. The other three countries in the region, there is no residents. Psychiatry in primary care may address the gap in the treatment and giving the treatment to large population. Health promotion and public awareness will be another issue. Health financing and health coverage will be another issue. When I think what we can add also will include stigma, fighting against the stigma, discrimination, and getting people on board. These are my references, and I would like to open the floor for everybody.
Thank you very much, Jibril. It was a wonderful presentation. And well, yesterday, my co-chair Lolapo and I were listening to your rehearsal, the long version, because Jibril can talk for hours about this, and he loves this, and it's really his work and what he has been doing for years. And then the second time also, I keep learning a lot. So right now,
and the Dabo is back now. You're welcome.
right now our co-chair Dolapo is joining. Jibril, you can stop sharing screen and then we can see the grid view of the speakers or of the attendees. Sorry, and people who want can turn their camera on, and we'll make a screenshot of
now
us.
I removed the screen sharing.
Hi.
Yes, please.
Hi, Binka. Hi, Jibril. Excellent work. Am I audible?
Thank you very much for allowing me the opportunity to present one of the most neglected mental health issues in one of the most difficult places on earth.
Sure. Okay. Are you being able to stop the screen share?
I stop it. That I am
Yes.
removing it.
Binka, can you make it full screen?
Okay, now.
Now it's done.
Great.
Okay. Perfect. Yeah. So if people want to turn their camera on, and we will start taking some pictures. Okay. Probably need a few screens. Okay, the first one is going. Smile. Okay. We'll take now another. Well, people are joining.
We wait until everybody opens their camera.
Well, those who want.
Yeah, those who want, please.
Exactly. Dorothea is there from Hungary. Okay. Okay, Leonardo. There. Okay, we are gonna take the second picture now. 3, 2, 1, smile. Okay, hey, Tanai was not here. Last one.
Yeah, hi. Am I visible now?
Okay,
Yeah.
3, smile, 3, 2, 1. Okay, thank you very much.
Great,
So now it's my pleasure. Now she could join to introduce the session co-chair, my colleague and friend Dolapo. She's from one of the young promises of Nigerian psychiatry, and as I said, she was awarded with a EFPT Menta Overseas Award this year, and was able to participate in the FPT forum in July. Dolapo, you want to introduce yourself?
Thank you, everyone. I am Dolapo Adedapo from University of Loring Teaching Hospital. I am a 50-year psychiatric training, and I am privileged. I was part of the 2020 FPT forum, where I met Victor in one of the breaking rooms, and it was an interesting experience. Really, we learned about leadership skills, how to start our NTA, that's National Training Association. We also learned quite a lot on how to relate better with others and group people up to be committed in the NTA. And we also had other informative sessions. So thank you very much. I'm glad to have everyone here, to see everybody. I will also shortly talk about the mental health challenges in West Africa. One major one is the lack of mental health acts in most of the countries in West Africa. For example, in Nigeria, where I practice, the mental health policy has been updated, but it has not been passed into law yet. And though we've had the third hearing, and we are hoping that soon it will be passed into law. But because the Mental Health Act is still not functional, we've been using the Lunacy Act of 1958. That's not appropriate, I would say, but that's still part of the law, except it is changed. So that has also affected part of the management of our patients, but we hope things will get better. Other challenges that we are facing in West Africa and also Nigeria is that we have about 0.09 psychiatrists to 100,000 population. That's less than one for every 1 million, for 1 million population in Nigeria. So that's a serious one, and I believe things will be better with time as more psychiatrists in training become psychiatrists. There are even certain countries in West Africa that they don't even have any psychiatrists at all. So that's part of our major challenge that we face in Nigeria. And also, I also noticed, and it's a major problem also, that the psychiatrists are not evenly distributed. We have more psychiatrists in the south than in the north, more in the urban area than in the rural areas. And so it's not everybody at the grassroots that gets psychiatric care. Mental health care is still less than 80%. The treatment gap is still about 85%. So those are some of the challenges that we face here in Nigeria. And then the culture of male dominance, the culture of child marriage, all these also affect the mental health of individuals, of children. For example, child marriage, the Child Rights Act is yet to be passed into law. It's been passed into law, but it's yet to be implemented in some of the northern states. So child marriage still goes on in some northern states in Nigeria. But we believe that once the Mental Health Act has been passed into law, some of this would change. Thank you very much, everybody. It's nice having you here. Thank you.
Thank you very much, Dolapo. We will have a little time for questions. I saw Dolapo will collect the questions if you are putting them in the chat. But before she joined, I saw a question from Sheikh from Kashmir in India, and he's also doing a lot of local and global mental health from that region of the world that is. They have a lot of challenges also with COVID, with internet access for telepsychiatry, with previous conflicts in the zone. And he's asking Jibril if you can talk a little bit more about the attitude and perceptions of religious leaders in the Horn of Africa towards mental health.
Yeah, thank you, Sheikh, for asking me. The mental health perceptions of religious leaders, whether Christians or Muslims, is that they prioritize mental health disorder as a spiritual problem. They don't regard this as a mental health issue. And that means they keep a lot of patients unnecessarily in their sphere of treatment. Where I worked, for example, in Somaliland, we had to break this stigma and the lack of communication with them. And then we had to put a lot of religious leaders in our grant application even as a part of the people who were the consulting team. And this gave us a opportunity to have them on board. And then what they did was that they had to refer patients to us. And then we had to treat patients. And we had to work together. Sometimes we should invite them to be part of the treatment team. Although they would not prescribe anything, they would just give religious guidance. And this was one of the areas that was successful in changing the perceptions of religious leaders towards mental health disorders. But in places like Eritrea and Ethiopia, religious leaders have a strong power in deciding the mental health situation. And that's where 85% of our patients go in the first place. And then in the future, that's where we need to tackle if we want to increase the number of people who would go to psychiatric services. Thank you, Sheikh, for the question. I hope I answered your question.
Thank you. Thank you. Okay. Yeah. So Darpan, if you wanna ask your question, Darpan is from India.
Okay. Hello, everybody, and greetings. Jibril, it's been a great presentation. Listening to you, got such useful insights, and thank you, Victor. You're doing a great job, and it's been really nice to get such a wonderful global perspective. I just have two questions to ask you, Jibril. One is that how do you see super specialty services? Like, what is the I would like to know about child psychiatry services or any woman in perinatal. What is the current scope in Africa? I mean, have they begun areas where a child or woman or infant or some higher specialties, are they working on it? And second is, you asked any more. So I just wish to know your thoughts on how do you see technology and social media? How can it be used for improving training programs and improving better collaboration amongst all the psychiatrists, especially, and the other mental health professionals? And I was very surprised to see in your slides that the occupation therapist, you have marked it as zero or very minimal. So I specifically would also like to know that why are some specialties not represented at all? So thank you very much, and I look forward, and really well done. Excellent listening to you. Thank you.
Thank you, Darpan. Let me tackle down your three questions. The first question is higher specialty trainings and services for people like women's mental health and child and adolescent health services. In East Africa, we don't have these specialties at all in the region. Ethiopia, Somalia, Djibouti, Eritrea, and so on and so forth. And what we have is that we have these global partnerships, like mainly led by the University of Toronto in Ethiopia and the King's College London in Somaliland, where they put their trainees and experiences and willing child and adolescent psychiatrists coming in and training people on this area and also setting up services. And these services only come from global partnerships. I think we could also benefit partnerships from the South, like India, like South Africa, like the places like that, where people like you can jump in. The second question is telepsychiatry, and it is still relevant for psychiatry training and also for services. I think we have been using it the last 10 years, telepsychiatry in East Africa. And this has been very useful. For example, the services I was running was mainly run on the shadows of telepsychiatry. Because that time I was just a GP, but we had all this input from modestly because of the telepsychiatry and the inpatient visits. And this gave us the ability to present cases or deliver and health services together. And then we had this partnership with the Karolinska Institute, where they had to try for the first time using telepsychiatry treating patients. Like we had two psychiatrists from my country who are senior addiction and child and adolescent psychiatrists in Karolinska Institute in Stockholm, Sweden. What they had to do was that we had to set up a telepsychiatry setting where they had to deliver the services through telemedicine. That was in 2011, 2012. And that paper has been published like 2012. That has been already in place already in the region. And the third question is, let me remind me the third question. You have one question left.
It's been about your slides on occupation therapists and
Yes.
other specialists within your country. Yes.
Yeah, we don't have any training. This is where we should be benefiting from future partnerships in setting up training services for occupational therapists and also social workers. There were only 3 or 1 for the country. They were also non-existent, basically. The only way we can tackle these is to collaborate with others and other countries that have the same experiences and setting up services. That's the only way we can tackle, because there is no expertise in countries to set up these services at all. That's the situation that happens.
Okay, thank you very much, Jibril, for answering those questions. I would like to call on Muftal to ask his questions. Muftal, can you please ask your questions? Thank you. Is Muftal still there? Can you please unmute and ask your question?
He's unmuted. No, you are muted now. You have to unmute. Okay.
Okay.
Now, try to speak.
Now.
Yes, try to speak. Okay, well, don't worry. Well, we work this out. We are going to go to the question from Isa, and hopefully Muftal can ask the question later. And if the mic is not working, you can also ask the question through the chat. But so Isa from Indonesia, her question is, how about ECT, electroconvulsive therapy, anesthesia, and transcranial magnetic stimulation modalities in your country or in general in the East Africa and in Africa?
Yeah, we have ECT facilities in the two countries in the region, Ethiopia and Somaliland, where we have to train the anesthesiologists and physicians, and this is given as a mode of treatment. But it has magnetic stimulation therapy. This is not available in East Africa. I cannot comment on West Africa. I may ask Dabo to comment on that. But in East Africa, I'm sure we don't have TMS, but ECT is available.
Okay.
Yes, in West Africa, we have ECT. We do the modified ECT for our patients. But for transmagnetic stimulation, well, we don't have that yet. But ECT is available, and we do that as necessary. We also call on the anesthetist to work with us when we have to do ECT. Thank you.
Great.
So I want to know if Muftal is ready now for his questions.
Well, can I confirm you can hear me now?
Yes.
Yeah, we do.
All right.
Yes.
Thank you very much, Jibril, for this wonderful presentation. And good to meet you online again. I just want to make a few comments about the mental health, global mental health generally. So one other important thing about the funding in mental health is the fact that a lot of the allocation is to the mental hospital, the large mental hospitals where I work, for example, and that's actually perpetuates the stigma. And then more of community-based mental health care is not given a priority, and that's a major problem. And I think there's also need to generate evidence, to do a large community-based epidemiological studies to generate evidence, and that will inform policy, actually, due to this huge treatment gap. In some countries, for example, Somalia, as you mentioned, and Eritrea, the situation is actually horrific, and something has to be done. And in those instances, maybe doing large-scale community-based epidemiological studies to generate evidence that will lead to some policy change would be possibly the priority research question that may be answered, because advocacy is very important, because it's an important means of raising awareness on mental health, ensuring that mental health is on the national agenda of government. This will hopefully lead to improvement in policy, legislation, and service development. The World Health Organization has already been clear about this. About the training of specialists, we need specialists really. In Nigeria, we have psychiatrists to the population ratio of about 1 to 1 million. That's grossly inadequate. But we also need to possibly review the curriculum, the psychiatry curriculum, the training curriculum, to prioritize mental health, community mental health in these aspects, because what the number of patients we see in the hospitals are actually just the tip of the iceberg. The majority of the patients are in the community, believing in spiritual and other forms of causations for their illness, and majority of them do not have access to the care they need. So there is need to review the curriculum to produce specialists that would potentially go to the communities to engage in advocacy, engage in services, service development, engage in training and supervision, rather than producing psychiatrists that will just stay in the clinic and then calling the next patient. What a professor called producing the next professional. You know, somebody sitting in the consulting room and then calling and seeing just a few patients in a day when the majority of the patients are there in the community. So, but another important aspect is also research collaboration. Thanks to the World Network of Psychiatry Trainees, funded by Victor. Thanks for that wonderful job. I think it's an important platform to collaborate and answer priority research questions that will lead to the reduction in the huge treatment gap we have, particularly in low and middle income countries. I know in the mental health situation in Somalia, because I'm a psychiatry resident, but I've also acquired a master's degree in child and adolescent mental health. So one of my classmates actually is from Somalia. And I think the research he did in his master's thesis, I think was the first kind of epidemiological study, because he looked at the mental health state of individuals in the internally displaced states and others living in their communities. And he looked at the mentals. I think he has not published that study yet because he just finished the master's degree program just last year. So overall, I think it's a very important, it's a very interesting topic. And we hope to collaborate to bring about changes in mental health so that individuals have access to mental health care, even the most vulnerable individuals within the communities, those in the IDPs, the refugee camps, and so on. Thank you very much.
Thank you very much for the comments. I intentionally left the parts on global mental health because I was to keep the time, and all the points you raised are very, very important: advocacy, human resources for health, and the institutionalization, both in psychiatry in primary care and in community psychiatry. That's one of the things that we can defeat. And this, the evidence from the WHO is huge and well supported. Thank you very much, Mustafa, for that. And in terms of the research is the only way, data, the way we can defend and advocate for mental health policymakers if we want to make a change in mental health and service delivery. And all of us is our opportunity. And in many countries, the data should be and produced. And I would like to remind you that there are so many projects now going on in many African countries where they're studying the evidence for primary care and mental health. And when this is out, we hope that this will be integrated. And training mental health professionals, as we see from West Africa and East Africa, is one of the most important things to address the treatment gap. And the treatment gap is the same everywhere: Nigeria, Ethiopia, everywhere. Thank you very much for the feedback.
Yeah, thank you very much. And just kind of some concluding remarks. I think, yeah, we have learned a lot about the Horn of Africa, all those challenges, and it's, in a way, it's kind of striking to see all that is happening there, and all the difficulties, and some and that in some places there are no psychiatrists, and that you will receive treatments that are not evidence-based, or sometimes can be harmful. But it's also hopeful to see people like you that are moving the field forward, that are really struggling to make things better, and we are very happy to have you and to have met you in WNPT. And I think yeah, and that's something that when I talk to Jibril, and we agree on that, that global mental health is not just an endeavor of knowing what is going on in the poorest countries in the world and seeing all the hyenas and all that. But global mental health, it's a task for every one of us. It starts in our practice. It starts with the patients we see every day. And even here in New York, so here we have the Empire State, and we have a lot of rich people, but we also have a lot of healthcare inequalities. We have a lot of homeless people. We have, and we are seeing inequalities in access, and especially mental health access. We see racial disparities. So global mental health is a task for everybody, every one of us, and we can first, well, address the local problems we have, but also we can learn a little bit more about what's going on in other parts of the world. And WNPT wants to encourage this and wants to keep having meetings like this from time to time. We'll also be partnering with national trainees associations. Last month, we were supporting a meeting on global mental health that was held in Indonesia with Eka and Darian and Amchad and all the colleagues there. We are also be alternating our meetings or global forums with other activities from other partners. For instance, the FPT, the European Federation of Psychiatric Trainees, is having next week, October 1st, question and answers with Professor Norman Sartorius, who is a champion in global mental health, and we are so happy that he's still very active and with us. So we have to take advantage that he's with full energy. And in November, so the Brazilian Association of Psychiatric Trainees is going to have their inaugural forum, and they will send us a link and more information. Do you want to give kind of a one-line concluding message before I wrap up, Jibril?
Yes, I would like to give one important conclusion for this. Global mental health is for everybody. And global mental health addresses the disparities in health, as you said, in terms of delivery, service planning, and health service delivery, financing, advocacy. And this year we have the World Mental Health Day, and it addresses health for all, addressing the universal health coverage for all, and also advocating mental health for all. As you see in America, where Victor we are based, the disparities are very clear between the rich, the poor, the colored, the white, people who are rich, people who are not rich, all about the world. The picture is even worse. And addressing issues like human rights, health equity, and health advocacy will be areas that we all work as a junior psychiatrist and people, whether we are in training or when we become like seniors. Because global mental health is the job of everybody. It's not the business of low and middle income countries, it is for the whole world. And I think something I would like to underline is that we have to do more research and evidence. We have to generate evidence and collaborate in different countries and help to change the world. Now the world is aware of the need for mental health and non-communicable diseases, and we can grasp that opportunity. And I think it is for everybody. And then we hope to see many of global mental health stories from different continents, and then we learn from each other. Thank you, Victor. Thank you, everybody. I would like to conclude on that.
Yeah, it's time to wrap up this forum. I hope you have learned from Jibril and other colleagues, and you feel encouraged to keep collaborating for global mental health in the Horn of Africa, but also in your offices, in your cities, in your towns. The challenges ahead to ensure proper and equitable care and respect for human rights for people with mental disorders are huge, but all together, just we can. So thank you and have a great weekend. Thank you all.
Thank you. Thank you, everybody.
Thank you. Thank you, everybody.
Thanks a lot.
Okay.